Brittany. Appreciate the introduction. Thank you, everyone who's logged on. Appreciate your time this evening. My goal today is to cover two main topics focused on men's health. This is the signs and symptoms of erectile dysfunction, as well as stress urinary incontinence. Again, as Brittany mentioned, the idea of this talk is really to inform the public and patients about the options available to them. So please feel free to reach out and make this interactive and put any information or questions you have in the chat. Here's my introduction. I look a lot younger in that picture. Otherwise, same. So I'm a urologist at Urology of St. Louis. I have offices in the St. Louis area at the Walker Medical Building, which is near Missouri Baptist Hospital, as well as an office over at Anderson Hospital in Illinois. I did my training in urology at WashU in St. Louis. And then once I was done at WashU, I spent a year in New York really focusing on men's health issues. So my fellowship was focusing on urinary incontinence in men, sexual dysfunction in men, and then fertility treatments. I'm going to focus today on mostly incontinence and on erectile dysfunction. Again, happy to answer any questions at the end. So to start off the talk, I'm going to talk here about understanding male stress incontinence, what it is and what the treatment options are. So what is it, who has it, and what causes it? So on this slide here, I think you guys can see my pointer on here. You see the urinary process. So not pictured above the slide are the kidneys. A person normally has two kidneys. The kidneys then make urine as they filter through the bloodstream and then send the urine down into the bladder. And the bladder is a muscle. I usually think of it kind of like a water balloon, where it stretches in order to hold the urine until it reaches capacity. When it's full, your bladder then can squeeze and push the urine through this tube here pictured, which is the urethra. At the base of the bladder is the prostate, and then right beyond the prostate is this sphincter muscle. Inside the prostate, there's some sphincter muscles or some muscles that protect you from leaking. So when you cough or sneeze or lift something heavy, there's a contraction of muscles here inside the prostate, and then especially contraction of these muscles here in the sphincter mechanism that are really always closed until you want to urinate, and then they open up and relax to let the urine flow. So this process, even though it sounds simple, and I think that we don't think about it every time we do it, is a complicated system. And there's multiple reasons why a man can have incontinence. The thing I'm going to focus on today is stress incontinence. So stress incontinence is when a man leaks, when they cough, sneeze, lift something heavy, and there's an increased pressure on their belly, and that pushes the urine beyond those sphincter mechanisms and the urine leaks. In addition, there's another type of incontinence that's really common that's called urge incontinence. That's that frequency and urgency and that overwhelming need to say, I gotta go right away. And the bladder just contracts and pushes the urine out outside of your control. In addition, there's some men that have both urge and stress incontinence. The most common reason that someone will have stress incontinence is because they had some type of surgical manipulation that injures that sphincter mechanism. Excuse me. The most common reason that happens is prostate cancer surgery. So when a man has their prostate removed, especially for prostate cancer, what happens is you lose the mechanism of protection that's inside the prostate, and so you're only left with the muscle that's beyond the prostate to protect you. Most men leak urine right away after the prostate's removed, but that does recover in the majority of men in that first year after the prostatectomy, leaving around 10% of guys that have significant leakage of urine after their prostate surgery that needs intervention. In addition, there's lots of other reasons that a man can have stress incontinence, and those include neurologic disorders, enlarged prostate, more commonly enlarged prostate surgery, radiation therapy, or pelvic trauma or pelvic fractures. So focusing a little bit more detail on the most common reason for stress incontinence, which is a prostatectomy or removal of the prostate for prostate cancer. If you look at the picture here on the right, this is a picture of the bladder. This is a man laying down compared to the other picture we showed before that was standing up. So the bladder sits here, the prostate here right beyond, and then the urethra where the urine goes through. when you have a prostatectomy, when the prostate is removed, most commonly now done with a robotic approach, an incision is made or a cut separating the prostate from the structures. And so this dotted line here removes the prostate from the bladder, and the dotted line here removes the prostate from the urethra. The nerves that run alongside the prostate, which are important for continence and also is very important for erections, which I'll talk about more later, are moved off the prostate. And then you have this opening here, and this is sewn back together where the sphincter muscle is brought right up to the bladder. As I mentioned, prostatectomy is the most common reason for a man to have stress incontinence, partially because there's so many prostatectomies that are performed in the United States, approximately 70,000 a year. And 1 in 10 men, more or less, have significant stress incontinence after that procedure. So after a man has their prostate removed or has a different procedure that causes stress incontinence, the next most common reason is when the prostate is removed for non-cancerous reasons, things like a TURP or a nucleation of the prostate does a similar type of damage to the area. Also, pelvic fracture is a really common reason where a man would have stress incontinence. Again, leakage of urine when they cough, sneeze, or lift something heavy. So if this is what's going on, the first thing we usually recommend are trying to do behavioral modifications, things that you can do to reduce this type of leakage. Therefore, if you know that when you exert yourself, you leak, going to the bathroom prior to physical activities is often really commonly advised, planning your restroom breaks. In addition, we work really closely with pelvic floor physical therapists, working with men after their surgery to do Kegel exercises, so to strengthen the pelvic floor. In addition, other exercises to really restore that natural muscle that's there to allow a man to regain their continence. In addition, other things like pads, diapers, and catheters are coping mechanisms that you can use to help with urinary loss. So if a man really has tried those therapies I mentioned and has significant incontinence after their prostate surgery, and for over a year after their prostatectomy, there are 2 surgeries that I really want to focus on that are available to men for help and a permanent help for these issues. One is a male sling. A male sling is a surgery where a piece of mesh is placed under the urethra to help support and reposition the urethra in a way that allows for less leakage. This has a man urinate the way they normally do, but now has his backboard present behind the urethra. So when you cough, sneeze, lift something heavy, the urethra is better positioned in order to protect from leakage. And the other is an artificial sphincter. This is where a man's natural function really doesn't work, and we replace it with a cuff around the urethra that does what the sphincter mechanism was supposed to do, permanently holding pressure on the urethra, preventing urine from leaking through until you squeeze a pump that allows the urine to go through. So in a little bit more detail on these surgical options for a man with stress incontinence. One is the sling. So the way the sling works is you focus in here where the sphincter muscle is represented here with the small blue line. And this mesh is placed on top of the urethra and then looped through the obturator canal in the hips. The mesh is then tightened around through the hip bones. And then as it's tightened, it kind of folds the back of the urethra behind itself, giving a stronger backboard for the urethra. So that way, when a man coughs or sneezes or really lifts something heavy, this extra backboard allows the sphincter muscle in order to function better, acting more like a hammock or repositioning the urethra, allowing less leakage to occur. In men who are appropriately screened for this surgery, there's a very high satisfaction rate. Over 90% of patients are happy with it, and over 90% of patients would recommend it to a friend. This is a procedure that's either done outpatient or with a short overnight stay. There's no interaction that's necessary for the procedure. I really think that this is a very good option for a man that leaks after their prostate removed and leaks up to 3 to 4 pads per day. A man with mild or what would you call moderate leakage, where you have some control and just need this extra boost in order to get your control, is the guys that have the best results from this sling. We would have to do a couple tests in the office to look at the sphincter muscle, make sure that everything looks appropriate. That's done with a cystoscopy or a camera that looks through the urethra in order to see that you're a candidate for the procedure. and then do some other testing and discuss it. So the other option, which in my mind is the gold standard, it's been around for the longest period of time, is an artificial urinary sphincter. As I mentioned before, this is a cuff that goes around the urethra. It's then controlled by a pump that's in the scrotum or in the skin next to the testicles, and then has this balloon that's in the abdomen that pushes this constant pressure on the urethra. What you do is every time you want to urinate, you squeeze this control pump, you squeeze this button that's right here, and the urethral cuff opens, allowing the urine to come through. You'll see on this video here an illustration of what happens. The pump sits inside the scrotum. When you squeeze that, you open the cuff. The cuff then takes away the pressure on the urethra, allows the urine to go through, and then slowly over the course of 2-3 minutes closes it on its own, allowing continence again until your next void. In my mind, a artificial sphincter is really an excellent option with over 90% of satisfaction. It is a very interactive device, so I really use this for guys that really need it. Either men that have severe incontinence, or men that have tried a sling and it hasn't worked, or men that had their prostate removed and then had radiation therapy and continue to have incontinence, are men that really are very good candidates for this artificial sphincter. Again, a workup would have to be done in the office in order to assess if you're a candidate for it. But what's nice is that if you are someone that needs this, there's really not an upper limit of how much leakage you can have. I've had patients that leak 6-8 diapers per day. We put this device inside, and the goal is for them to leak 1 pad or less per day. In my practice, the artificial urinary sphincter patients are the happiest patients because these are men that are often leaking very heavily that affects their quality of life. And by restoring their continence, they become very happy. They're able to interact and live the life that they want to live. Both these procedures, like I said, do restore continence for men, but there is significant risk, especially with an artificial urinary sphincter. These are devices that are placed inside the body, so there is a risk of infection. We give antibiotics before, during, and after the surgery in order to reduce the risk of infection, but it doesn't make it zero. There's a risk of injury to the device. There's a risk of going to general anesthesia that's necessary to have these procedures performed. For the most part, these procedures are covered by insurance. These are because the incontinence is a complication of prostate surgery, and for the most part, in most men, they do have insurance coverage. That said, before we would do a procedure, we would verify that you are a candidate and that your insurance covers it, or if it doesn't cover it completely, you would know what your out-of-pocket expense would be. I know I give a very brief overview. There's a lot more information about stress incontinence, as well as sling procedures and artificial urinary sphincters on fixincontinence.com. I was going to open it up real quick for some questions and then move on from there. But if you have stress incontinence after your prostate procedure, maybe to summarize, important to talk to the urologist you're currently seeing, talk to them about your incontinence, especially if it's someone that's in our group. Let them know that you went to this webinar and that you'd be interested in hear about more options for stress incontinence, and they can refer you over. It's really common for men to have stress incontinence after the prostate surgery. Like I said, in many men, this does get better with time after their prostate procedure, and usually up to a year, but sometimes up to 2 years after the procedure, they continue to get improvement. But if you stop getting improvement, if you're very much bothered by your incontinence, it's very reasonable to talk to your urologist or talk to someone like me, a prosthetic urologist, about the options to fix stress incontinence. So, Brittany, I know I went quick. Do you have questions on there about incontinence, or do you want me to move on to ED?
I do have one question, although you did just address it, but just to acknowledge the question, I'll start with, or if someone who did have a recent surgery, right, regarding their prostate, and now they do have incontinence as well as some ED, and they're responding to Viagra, is there a procedure that can help them cure their incontinence?
Yeah, definitely. So, and I think that's a really good segue into the ED portion. But For a man that has leakage after their prostate surgery, you know, especially if it's a recent prostate surgery, one, time will hopefully help improve those things. But in the initial time period, that first year after the prostate surgery, really important to be pretty good about your Kegel exercises, which are the pelvic floor strengthening exercises you can do at home, or working with a pelvic floor physical therapist, a specialist that can really help you isolate and find those muscles. So you know that when you're doing your Kegel exercises, you're doing a good job really focusing and finding the right muscle. And the literature would say that 50% of men would have an improvement in their continence by focusing and working with a pelvic floor physical therapist. But if that man continues to have leakage after doing those things, I think a sling or an artificial sphincter are very reasonable things. It sounds like the patient you're mentioning has pretty mild leakage, which in my mind would be less than 4 pads per day. And a sling would be something to consider, especially if they're a year after their surgery.
Awesome. That's the only one. You're free to move on if you'd like.
Perfect. Then I will do that. Okay, so changing gears slightly, I'm going to talk about erectile dysfunction and what the treatment options are for that. So erectile dysfunction, or commonly known as ED, who has it, what is it, and what are the causes? And so what is it? So everyone has their own definition of what ED is, but the generalized idea is that it's the persistent inability of a man to achieve or maintain an erection that's firm enough to have sexual activity. And it's really common. And I think these are the numbers that really, I think, are surprising often, is that 1 in 5 American men have erectile dysfunction. And it's more than half of men over 40. And so it ends up being about 40 million men in America have erectile dysfunction. And it is a very common issue. There's lots of reasons why a man will have erectile dysfunction. In general, what causes ED? And the thing is, before I talk about what causes it, let's talk about what the anatomy is that we're focusing on. So not pictured here is a man's brain. Some of getting an erection starts in your head. You have to be in the right mood. You have to be in the right situation. You also have to have normal ability of the nerves from your brain to get down to your penis, and the normal blood flow to go from your heart down to your penis. Once that happens, and that stimulation from your brain gets down to the penis, oftentimes that stimulation will then cause the erectile bodies in the penis to fill. So when I think of the penis and getting an erection, I think of the penis as 3 tubes. There's in red here, the erectile bodies. These are 2 side-by-side tubes that have a blood vessel that runs through them, which is an artery. And then when blood is delivered, it fills those tubes, almost like 2 long water balloons that fill with blood in order to get the erection. And underneath is the structure here in blue that we talked about before, the urethra. Many medical issues can really impact that pathway that allows a man to get a normal erection. As I talked about before, this is a phenomenon where blood fills the penis in order to maintain the erection. And so the most common reason a man has issues with getting erection is vascular issues, meaning blood doesn't flow in their body the way that it used to. In addition, diabetes is really common. Diabetes is a blood sugar issue that's very common in the United States. I'll talk about it a little bit more in a moment. Diabetes and increased blood sugar in the body can affect the blood vessels, so therefore cause a vascular problem. It can also cause injury to nerves and affect the way that the brain signaling doesn't get down to the penis the way you want to with neuropathy. Different medications, especially blood pressure medicines, prostate surgeries, pelvic traumas, and hormonal issues like testosterone issues are really common reasons for erectile dysfunction as well. So I'm going to break down a few of the really common disease states that we see that can affect a man's ability to get an erection. So one is diabetes. So diabetes is really common. In 2012, we said it was 15 million American men have diabetes. Men with diabetes tend to get erection issues much earlier than the general public that gets erectile dysfunction, probably 10 to 15 years earlier. And then men with diabetes tend not to respond to the typical treatments that we give for erectile dysfunction, which is pills, as well as the general population. And so men with diabetes are more likely to have erection issues and then be harder to treat because of a lower response to pills. If a man has diabetes, what are some additional risk factors for them to have problems with erections? Well, one is age, definitely not something you can control, but other things like glycemic control, better control of your diabetes, keeping your sugars as well controlled as possible, reduces the risk of having complications of erections with their diabetes. Erectile dysfunction and heart disease. So as I mentioned before, getting erections is a vascular issue. So in order to get the blood to flow into the penis, it's transported by the penile artery. The penile artery that runs, there's two, one per each side into the penis, is about 1 to 2 millimeters in size. This is a pretty tiny artery and therefore at high risk of getting narrowed in anyone that has vascular problems like high cholesterol, high blood pressure, things like that. If you think about the coronary artery, the blood vessel that gets blocked up when a man has a heart attack, that's 3 to 4 millimeters in size. That's significantly bigger. So any man that tells me I had a heart attack or I have a heart stent or I know that I had a CABG, a coronary artery replacement surgery, that tells me that that man has such bad issues in their blood vessels in the heart. It's almost for certain that they have some issues with the blood vessels in their penis. Ways to reduce your risk of heart disease: exercise, diet, not smoking, and trying to reduce your stress. And also taking appropriate medication to help reduce the complications of heart disease. Erectile dysfunction and low testosterone. So testosterone is the hormone that's made from a man's testicles. The testicles have two jobs. They make sperm, they make testosterone. And as a man ages, their production of testosterone does drop. Approximately 40% of men over 45 do have low testosterone. Low testosterone is considered a blood testing of your testosterone level in the morning, usually before 10 a.m. That's less than 300 nanograms per deciliter. We check that twice. If you have two blood tests that show a low testosterone, you're considered having a low testosterone. Other risk factors to having low testosterone are things that also can affect erectile dysfunction in general, like we talked about before: being overweight, having diabetes, having high cholesterol, having high blood pressure. So I do check a testosterone level on every man that comes in with erectile dysfunction. And oftentimes it's at least one correctable thing that we can give a man to help with their erectile dysfunction and definitely to help with their desire. The most common signs a man will have of having a low testosterone, one is erectile dysfunction, but in addition, it's feeling fatigued, feeling run down, poor concentration. Oftentimes they'll feel sad or blue and have less motivation. So I have lots of men that I treat with a low testosterone that has nothing to do with sexual dysfunction. So if you have those symptoms, it's very reasonable to talk to your primary care doctor or talk to your urologist about getting your testosterone checked. Again, I said it's most accurate if you check your testosterone level in the morning. If a man's verified to have low testosterone, there are lots of treatments available for it. And it's really exciting because there's been, in the last 5 years, 5 new drugs that have been approved for testosterone. So options for testosterone include gels you put on your skin every day, injections you do once a week, either into your muscle or under the skin. And excitingly, there's some new pills that were FDA approved in the last few years that can raise your testosterone. So erectile dysfunction and prostate cancer. This picture should look familiar. This is the same one I used when we talked about incontinence. What happens is when a man has their prostate removed, a line is cut here, a line is cut here to remove the prostate. Now, this neurovascular bundle that runs right next to the prostate and right very intimately associated with the prostate, that's what helps the nerve signaling go from your brain down to your penis to get an erection. So when a man has what's called a nerve-sparing prostatectomy, these neurovascular bundles are peeled off the prostate and preserved so they're not injured, allowing maintenance of your ability to get an erection. And then when this is sewn back together, does take time for these new nerves to recover. However, over time, 1, 2, sometimes 3 years, erections do improve in many men. However, approximately half of men who have prostate cancer surgery do have erectile dysfunction. In addition, some men not only have their prostate removed, they also have radiation therapy, or they have radiation therapy alone. About half of the men that have radiation therapy also develop erectile dysfunction, because what happens is the radiation beams, when they hit the prostate, do hit those nerves that are adjacent to the prostate. Erectile dysfunction and Peyronie's disease. So Peyronie's disease is a separate entity than erectile dysfunction. However, there are a large population of men that have both Peyronie's disease and erectile dysfunction. Peyronie's disease is scar tissue that occurs in the penis. What happens when there's a small trauma or injury, the penis gets bent or twisted. Oftentimes when patients don't even remember it happening, they develop this small injury, and that develops a scar or a fibrous plaque. That plaque then becomes less elastic than the rest of the penis. And so if you look here at this patient getting an erection, everything stretches in the penis except for the plaque. So with this plaque located here on top, the patient has an upward curvature because that plaque doesn't stretch when the rest of the penis does. There are lots of therapies available for Peyronie's disease. There's stretching exercises that we often offer, and there's something called a traction device that a man can wear on the penis in order to stretch that plaque out. There's one FDA-approved therapy for Peyronie's disease, which is a medicine called Xiaflex. That's injections into the plaque. And then in addition, there's surgeries we can do for Peyronie's disease. This includes a plication procedure, which is shortening the bottom or the opposite direction of where the plaque is in order to straighten things out, cutting out the plaque and putting a graft in, or finally doing a penile implant surgery. A penile implant, which I'll talk about more in a moment, would fix Peyronie's disease and erectile dysfunction. So I know that was a lot to go through quickly, but those are really the most common disease factors that we see that affects a man's ability to get an erection. And then my job now, I think, is to really talk about what options are available for that man that comes in that has erectile dysfunction. Well, nowadays, they're not always getting to me men that have erectile dysfunction. I think most primary care doctors and general practitioners feel really comfortable talking about ED. So starting with your general practitioner or your general urologist is a really nice way to start. But someone like me who's a prosthetic urologist, someone who focuses on the advanced therapies for erectile dysfunction is really the next step. So the things I'll focus on today are taking pills, oral medication, wave therapy, injection therapy, suppositories, vacuum erection devices, and finally penile implants. So pills are really the first line therapy that most men will use to help with erectile dysfunction. The way these work, the most common ones are Viagra and Cialis, but there's many others on the market. They're taken prior to sexual activity. They allow the blood vessels in the penis to be more reactive. So if you take a Viagra and don't do anything, nothing happens. But if you take a Viagra or Cialis and then engage in sexual activity, you'll improve how much blood flows into the penis. This works in about 60–80% of guys, and men are very satisfied with it when it works. It's really common for a man to get headache or stuffy nose or flushing if they take this medicine. So we try to figure out which medicine works for them and in what dosage in order to give you the best results with the least amount of side effects. You can't take PDE5 inhibitors, this class of medicines, if you take certain medicine, especially nitrates. And then alpha blockers, which are medicines like Flomax, should be separated from these medicines by a couple hours. Shockwave therapy or low intensity shockwave therapy are small pulse waves that go to the penis. This is a non-FDA approved option to help with erections. There's been lots of studies showing improvement of the microvasculature, so the small blood vessels in the penis can grow and cause neovascularization or new blood vessel formation when this treatment is performed. It's 20 to 30-minute sessions, usually 6 times weekly, and has been shown to give improved blood flow into the penis. Again, it's not approved by the FDA, so there's not great options to tell you exactly who the best candidate is, but we do know it's a low risk. There's very low or almost no reported side effects of these therapies, and it improves the amount of blood that flows into the penis. Vacuum erection device. This is a tube that goes over the penis, pulls blood inside, and then a ring is placed on the base of the penis in order to maintain the erection. About 70% of guys are satisfied with this type of therapy. However, there is discomfort associated with putting a ring on the base of the penis in order to maintain your erection that can cause a change in sensation, bruising, discomfort, and I do hear a lot of patients complain of a lack of spontaneity. Urethral suppositories. So this is a refrigerated medication that is placed into the urethra or the urinary tube, and a small pellet is then pushed into the urethra that then dissolves. As it dissolves over the course of about 5 to 10 minutes, the erectile bodies pictured here absorb the medicine and then become more engorged. This is a really uncommon option because of the expense and the discomfort associated with it, but in about half of men, they are satisfied. Much more commonly, I'll teach men how to give themselves an injection to the penis in order to get an erection. So if you look at this diagram here of the erectile body, the two cylinders on top, the erectile bodies and the urethra underneath, we teach a man how to give himself a tiny needle into the side of the penis that just delivers medication that's vasoactive, meaning it tells the blood vessels in the penis to dilate. So especially for men that have nerve issues where the brain can't talk to the penis, the medication takes that job and directly stimulates the penis. So men that have had their prostate removed, men with diabetes, oftentimes can learn how to give themselves an injection like this within 5 to 10 minutes, have a good response, be able to engage in sexual activity, and the goal is for the erection to last about half an hour to an hour, depending on which dosage you give. This is a very sensitive, so patients are really sensitive to this medicine. It does work very well, and so the first time we do it, we have a test dose in my office where we see a response to it, because there is a risk of having a prolonged erection or pain with the injection. And the last thing I want to focus on is a penile implant. A penile implant is a surgical procedure. What we do is we remove the inner parts of those cylinders in the penis and replace them with these cylinders here. The way it works is they are controlled by a pump that sits in the scrotum and a reservoir that sits in the abdomen. Similar, like we talked about before with the artificial sphincter, the pump sits inside the scrotum. You squeeze the pump in order to get an erection. You press the release button, and the erection goes down. It's very satisfactory for almost all patients. 98% of patients say they're satisfied with their penile implant, and about 94% of guys still use it at about 7 years after the procedure. It is a surgical procedure, and there are obvious risks that are involved with having a surgery, including infection, need for other operations, or having general anesthesia. There's different types of implants. Like I said, the idea of a penile implant is to replace the erectile bodies that are present and not functioning appropriately and filling with blood with either concealable bendable implant, something called an ambicor, which is a 2-piece device, or the most common thing is this 3-piece AMS device. Again, cylinders that go in the penis, a pump that sits in the scrotum, and a reservoir that sits in the low abdomen. As you can see, the AMS 700 is yellow in color compared to the others because the AMS device is coated in antibiotics. This antibiotics is slowly released over 2 weeks after it's placed in the body, and this allows for a significant reduction of infection. So if you look here, they say a picture's 1,000 words. Right here, when you squeeze the pump inside the scrotum, you are shifting the fluid from the abdomen into the erectile bodies. You can then pump it up and keep and maintain your erection for as long as you'd like. And then you can press that release button. And then what it does is it shifts the saline or salt water back into this reservoir until you want to have an erection again. So if you look here, this patient with his implant in place isolates the pump in the scrotum, gives the pump squeezes. Each pump shifts about 3 milliliters of fluid into the cylinders in the penis and allows for an erection to occur. And you can see it looks like a very natural and concealed erection. You can then keep your erection for as long as you want. And then what you do is you find the small button that's on the top. You can see the patient is pulling it right there up to the skin. Then you press the button And by pressing the button, you're opening a valve, allowing the erection to go away. And then oftentimes what my patient will do is once that valve is open, there's still some fluid that remains inside the penis. You give the penis a little bit of a squeeze, which I think he'll do here in 1 second. And then what that does is that shifts the rest of the fluid back. So you have a concealed device until you want to use it again. Again, satisfaction rate, I tell patients 90 to 95% of patients are very satisfied. And again, 90 to 95% of partners are satisfied with their partner's penile implant. Any surgery has risk. The risk we worry about the most with the penile implant, like I said, is an infection. That's why we give antibiotics before, during, and after the procedure. That's why I tend to use the Boston Scientific device, which comes coated in antibiotics in order to reduce the risk of infection, and try to do the procedure with as small incisions as possible. In addition, other risks associated with getting a penile implant are just being unhappy with the device for some reason, having a mechanical problem, having it not sit appropriately, or having pain. Pain is typical after the surgery, but does improve with time. I tell most of my patients that a penile implant is like wearing a watch, where when you get a new fresh watch, it feels different. But once you wear that watch for a week or two, you kind of forget that you even have it on your wrist. Again, it's designed to be a permanent solution for erectile dysfunction. It's spontaneous and concealed inside the body. It's inside the body, so no one knows that you have it there unless you inflate it and really show it off. And I do have patients that say that they'll walk around a gym and no one really knows that they have it there. There's been more than 500,000 of the Boston Scientific device implanted with a very high satisfaction rate. Penile implants are not guaranteed to be covered by insurance, but Boston Scientific, the company that makes the device, does a really good job partnering with us, making sure that if you choose to have a penile implant, we will know what your out-of-pocket expense would be. And the truth is the majority of patients do have coverage, especially Medicare patients. So in summary, maybe to take a step back from penile implant, in general, erectile dysfunction is a very common problem. About half of men over 40 have ED. There's lots of treatment options. There's really not one option that's right for everybody. There's a fair number of men on this talk today, and there's not one answer that's going to fit each of you. Really, my job, I think, is really to explain all the options that are available to you and to talk to your partner, talk to your doctor, talk to your urologist that you already have, or if you think that you want to do one of these more advanced things, talking to someone like me, a prosthetic urologist, to see if a penile implant or one of the other options is the right fit. So I'm going to jump ahead here, and I'm very lucky to have Cliff that can jump on and talk about his experience with erectile dysfunction, and then we'll answer questions at the end.
Hello, everybody. Good evening. I am a recipient of a penile implant, and basically what you're going to hear is the story that I took with my wife from the time I had ED till the time we cured ED. When I was 58 years old, I was diagnosed with prostate cancer. And it was one of those prostate cancers that really, when they did the biopsy, it only had one spot that was positive for cancer. But being the kind of person I was, I didn't want to wait and let it sit around and spread. So I had my prostate removed. After I had my prostate removed, I did suffer for about 3 months with a little incontinence. But what I was left with when that left was with ED. I went back to my primary care physician, excuse me, first, and they put me on Viagra. And they started with a lower dose and worked their way up. My problem was I just couldn't tolerate the Viagra. I got terrible, terrible headaches. And I would always end up laying down and putting my head on a pillow and not being able to do anything. So we switched to Levitra and we switched to Cialis, and all three I had bad reactions to. So I went back to my general doctor and he suggested this external vacuum device. Now I will say it does work. However, it is very unspontaneous, which is true. Secondly, when you use it and you put your band on, your penis does become a little blue and a little cold. And I must say, for your partner, it's not very, looking very good. Actually, I used it for about 6 months and then basically decided, we talked about it and said, no, this is not going to really work for us, and put it away, and then went into a major depression because I had no idea what was left as far as how to cure the ED. Luckily, at that point, there were seminars going on like this one, except it was before COVID, so it was in person. And I learned about the other 3 types of procedures. The little pellets that you could put in, which I wasn't interested in. I was less interested in the injections. But when they talked about the implants, my wife and I looked at it, spoke to the doctor about it, and decided that, basically that's something that's done and it's with you and it's there all the time. So when I was 60 years old, the day after my 60th birthday, I did the second best thing I ever did in my life, which was have the implant done. Yes, it was a little painful, but I was able to basically take some Advils to take down the pain. I didn't need to take any heavy barbiturates or stuff like that. After about 2 weeks, swelling went down. I went back to the doctor. He showed me how to use the device. I cycled the device, and after the sixth week, we started to have intercourse again. And what was interesting is we never realized how much intimacy we had lost in those 2 years, sexual intimacy. So at 6 weeks, we had intercourse. I went back to working at the gym. I started out slower than I left. I was shallow with the guys I played with, and they could tell there was nothing in my body at all. It's absolutely hidden. My implant lasted 14 years. I was in heaven. You get a very positive, rigid implant, and the erection is just solid. And the thing that's nice about it is you can keep it up for as long as you like. You don't have to worry about this idea about if you take a pill or an injection for 4 hours, it doesn't go down, you have to run to the ER. You can leave this one up for 4 hours, 40 hours, or 40 days. It's not going to make a difference. Not that you're going to do that, I hope, but you can. People ask me, what are some of the problems I've had with it? Truthfully, I've had no problems with it whatsoever. They ask me, well, what happens when you go through the airport and when you go through the devices for metal detection? The answer is nothing. I do have 2 artificial knees, and those knees do go off. And when they go off, they take you to the side and they take this wand and they wand your body and they come up the inside of your thighs, and nothing goes off, no bells, no whistles. The thing that's nice about it is it's with you all the time. You don't have to worry about keeping a medication in a refrigerator when you're traveling or anything like that. One thing I will say about, just to go back to the external vacuum device, there are the vacuum devices like that you can buy online from a lot of these sexual companies. And those are not the kind of devices you want. You want to get a prescription from your urologist to get a really good one from a medical supply company. You don't want a $25 one. So basically, all I can say is my implant lasted 14 years. When it stopped working, when I was 74, I had it replaced. I'm 77. It still works like a new one, works just like a champ. And I have absolutely no complaints about it. And it basically changed the way I looked at myself and I got my manhood back, because losing the power to have an erection really, really took away my manhood, and this restored it. That's really the best I can tell you. It's a wonderful device. It's been around for a long time, and I'll be more than happy to answer any questions if you have any. So I'll turn it back over to Dr. Goldenberg and Brittany.
Well, first, Cliff, thank you so much for sharing your story. Really appreciate it. Brittany, do you have questions that you want me to